Hello, welcome back to NeuraXis Care and Research Center YouTube channel.
To be on behalf of NeuraXis. I will keep my talk short because all of us are excited to hear what Dr. V.K speaks about the deep role of DBS in psychiatric disorder. I will confine myself to deep brain stimulation in the treatment of movement disorders. If we go into a brief history, it's very interesting. In late 1950s and 1960s, lot of surgical procedures were being done for Parkinson's disease, dystonia, and other movement disorders. And basically, these were thalamotomies and peripherotomies. But in late 70s and early 80s, levodopa came and the scene changed because levodopa was very effective in the management of Parkinson's disease, and therefore the charm of these destructive surgeries, that is thalamotomy and peripherotomy, weaned off. But 10 years later, that is in early 90s, those patients who were started on levodopa in early 80s when it came, they started developing side effects like dyskinesias. Some of these people developed resistance to the levodopa, and that is the time that again it was looked into the surgical treatment for the Parkinson's disease and other movement disorders. By the 90s, the CT scan had come, the MRI had come, stereotactic frames were married to these newer imaging modalities, and then by 2000, by the turn of centuries, the deep brain stimulation came, and so now the scene has totally changed for the management of movement disorders. For Parkinson's disease, the deep brain stimulation was FDA approved in 2002. The usual targets are STN, subthalamic nucleus. Sometimes we put in globus pallidus interna. New targets are being worked out. The ideal candidates are those which are levodopa responsive and who have the classical Parkinson's disease. This is very important that patient has a classical Parkinson's disease because the Parkinson's is a symptom of many other diseases. Now before that, who are the candidates for DBS? DBS is not the first line management of the Parkinson's disease. We only do deep brain stimulation if the symptoms are not well controlled despite receiving the appropriate dose of levodopa and other medication. If the patient has side effects of levodopa like dyskinesias, if the dose requirement of levodopa is more than 4 or more than 5 times in a day. Recently we operated a patient, he was taking levodopa every hour without a significant relief. If the disease duration is more than 5 years, that patient is a better candidate. It increases on time. It decreases bradykinesia and rigidity. It reduces the medication dose. If the patient has dyskinesias, it will improve dyskinesias. It will improve the gait issues and it will improve the quality of life. But we should know that what DBS doesn't help. If the patient has cognitive problems, it will not help.